appear essentially normal early in life. So this is one of our 3-year-old patients. And if you just looked at this, you'd say it looks normal. And I can tell you most of our patients, they went through MRIs and got diagnosed with autism and all kinds of sort of misdiagnoses until they finally were diagnosed appropriately. I show you this kind of busy slide, and it reinforces kind of what Dr. Sieving discussed, and that is that the long road towards approval from 1992 cloning of the RP65 gene all the way to 2017 with FDA approval of the Parvovec. Very exciting, and this is of course what we want, and it just kind of is a good reminder for us early career physician scientists that it can take a long time to get results. So this was the study that kind of clinched FDA approval. It's the phase 3 trial that led to approval of Richardine and Parvovec. It was 20 patients who were treated with this AAV2 vector that drove expression of the RP65 gene, and it led to FDA approval for subretinal delivery in both eyes. And these are the main outcome measures I think that led to approval. One is this mobility testing score on the left, in which subjects had to navigate through a maze at varying light levels, and you can see that those treated were able to navigate this maze at significantly lower light levels. Also on the right is FST, which is a full field scotopic testing, so it's basically like a visual field, except you get just a bright flash to the entire fundus, and then you're just asked to click if you see it, and it allows us to see what the threshold of light sensitivity is, and these patients did quite well, usually improving over 100-fold in terms of their light sensitivity. The visual fields also improved on Goldman visual field testing, an average doubling of the visual field isopters. The complications across all the voretigene trials, starting with the phase 1, included cataract, as you might expect with vitreoretinal surgery, vitrectomy procedure, inflammation at 5%. I think that's related to the vector, but there weren't any cases that led to any sequelae, really. Retinal tears were identified, and those were lasered intraoperatively. So heading towards FDA approval, Spark, the company that produces Luxturna, decided to create what are so-called ocular gene therapy treatment centers, and these are selected sites that would have specially trained surgeons to deliver this treatment rather than just allowing any retinal physician to deliver it. And CHLA is one of those sites. We had to undergo both kind of lecture-based and also wet lab experience. We all got together in Philadelphia more than a year ago to kind of undergo training. And then once that happened, we started seeing our patients and what is the workup that's involved. I first examined very carefully their genetic testing, because you really want to convince yourself that the mutations that have been identified are truly pathogenic and causing the disease you're seeing. Of course, the last thing anybody would want would be to treat on a false premise. And so I'm very suspicious when people come with single gene testing. I tend to prefer panel testing so we can see the landscape of retinal dystrophy genes and make sure that RP65 mutations are truly the most pathogenic and plausible disease-causing mutations. I perform segregation analysis, which means I test the parents in every case to make sure that, for example, compound heterozygous mutations are truly that, and that each of those segregates to one of the parents. In one case, we actually had a VOS, a variant of uncertain significance, which means a mutation that we're not sure whether it can cause disease or not. We actually worked with Mike Redmond at NEI and he was gracious enough to engineer this mutation into the protein in vitro to show that it was categorically inactive. And I think that's kind of the degree you need to take this in some cases. We perform an exam, OCT, optos, color, and autofluorescence, and we have excellent optometry support that helps us with that. We have Goldman visual field performed by our neuro-ophthalmologist, Dr. Borcher and Dr. Chang, and this is very useful in the younger kids where we can't really do a lot of the other testing. Full field scotopic testing, like I mentioned before, we do this to give ourselves a quantitative value to go off of. We're not doing any mobility testing, and none of the sites really are, and of course the testing is limited to children. So we have a whole team involved in the surgical delivery, starting from the pharmacists who make up the medicine and get there at 5 in the morning, to the perioperative nurses, anesthesia, and so on, who help us with this. And so we're doing a vitrectomy with a subretinal injection of 0.3 cc's of vector. And then we do the second eye 1 week later. We use the Med 1 microdose kit, which allows the surgeon to have full control over the delivery. So with the foot pedal, as if you're injecting silicone oil, you can adjust the pressure at which this vector is being delivered. We use a 38 gauge tip cannula. And in all these cases, we're using intraoperative real-time OCT, which helps to ensure that you've gone subretinal, and also sometimes to just determine the status of the fovea when it's impinging on the fovea to know whether it's detached or not. And then we do a full air fluid exchange, which allows us to prevent reflux from the retinotomy at the end of the case. So here's an example. This was a 10-year-old patient, and there's several things I want to point out. One is that it's really important to remove the hyaloid completely. So here's the posterior vitreous detachment being created. And it's actually surprisingly easy in these patients for some reason. So even, I've done a 3-year-old, and even the 3-year-old, it was possible, whereas normally it would be very, very difficult to do. So I don't get too aggressive with the posterior vitreous separation. I go about to the mid-periphery, at least here in the arcades and beyond that. I always check with triamcinolone to make sure I've removed all the vitreous. And then I select my site. We're instructed to go along the superior arcade, and I think that's a good place to start because it's far away from the fovea that it would limit the chance of developing a macular blowout or macular hole. So here you can see in real time the blood coming up, and you see it's clearly subretinal. I chose this case to show because this bleb in particular decided not to go into the macula. It kind of stopped at the optic nerve and then went on to the periphery, and the blebs do tend to have a mind of their own. You can't really control where they go. So in this case, I stopped here and actually created a second bleb, as you'll see, along the inferior temporal arcade, and so that I could hopefully get this one to come into the macula so I could treat more of the macula and into the fovea, and this one, in fact, did. Most cases, however, it does tend to dissect into the macula, so I don't have to do this, but I've done sometimes 3 or more blebs in order to treat more of the macula. So you can see here the 2 blebs side by side on the OCT, which is nice. This is kind of a more typical surgical case in which this was a myopic 12-year-old boy. You see there's almost a staphyloma there on the OCT. And in his case, the bleb was dissected really nicely into the macula. And this is what I tend to see in cases that have more atrophy, that it just kind of tends to dissect more into the macula for some reason. And I feel like that's an adequate treatment, although we're leaving a lot of retina untreated. A lot of that untreated retina is pretty atrophic, and I'm not sure if it's salvageable. So we've now done 28 eyes, 14 patients. 9 children, 5 adults, and ranging from 3 years to 44 years. We have pretty good follow-up on these patients now that we've been doing this for more than a year. What's really interesting is that the visual acuities don't budge too much. So they improve slightly, but not at a statistically significant level, in spite of the fact that a lot of these patients are saying they can see so much better in real-life conditions. Certainly the FST values do improve, and they improve pretty drastically over 2 log units, so that's more than 100-fold, 100 to 500-fold improvements in their ability to see light, and that's what a lot of patients will tell us. Visual fields expand as well. Here's an example of a 4-year-old who started off with a relatively limited here 5-4E isopter that expanded, and then a new isopter 3-4E cropped up there, and there's a scotoma here to the 5-4E, but patients do tend to have visual field expansion, and that was done by Dr. Borchard. He's really great with the young children. So it's a useful outcome in those patients who can't do the FST. What issues have we experienced? So I'll highlight a few of these. One is vitreous opacity, so inflammation is essentially from the vector. You can kind of see on the Optos picture, there's some black dots, and that's just some vitreous kind of particles that floating around, and I was concerned at first, but I've seen this in a couple of the young kids, and they just kind of go away on their own. We have 2 retinal breaks that we identified in the periphery. I don't think they're related to the PVD induction that were repaired with laser intraop. I had 1 retinal detachment from an inferior operculated hole, which I did laser intraoperatively, but I think with the air, it lifted up, and I repaired him, and he actually has done well. His FST in that eye improved by 2 log units. And then we've also seen decreased central visual acuity. And what we see is that there is some tenuous ellipsoid zone that's present in some areas in these adults. And as soon as they have the procedure, that ellipsoid zone can get kind of washed away. And what we've seen is a slow recovery to baseline, where at least to some extent that ellipsoid zone recovers over a 3-week period after surgery. So they do recover their vision, but sometimes not to the extent where they were before surgery. However, they all report increased light sensitivity and are quite happy with the surgery. I'd like to share with you this kind of touching story of one of our patients who's really sweet. He just kind of tells the journey of how she's improved at following surgery.
My daughter, Monroe Lee, had many challenges prior to the gene therapy. The challenges for her were not being able to see things. She constantly was bumping into walls or running into things, always had bruises on her legs. If it would get dark earlier in the day, she wanted to come inside much quicker. Since the gene therapy and just days after the gene therapy on her left eye, which was the eye that was treated first, she was able to find the ointment cap from an ointment that we used for her eyes. I accidentally dropped it, and Monroe immediately told me, "Wait, Mom," and she covered up her right eye, which was her non-treated eye, and was able to find the ointment cap on the floor, which was a black cap on a dark blue carpet. In the past, if she dropped a pencil or anything on the floor, she was always trying to use her hands to search around to locate it. So for her to just grab that ointment cap was just amazing. My sister decided to put Halloween decorations up a little early this year since Monroe's never been able to do Halloween. So we took Monroe out to see the Halloween decorations, but instead of looking at the decorations, she was running up and down the street.
What do you say?
It was 9:30 at night when this occurred, so it was really dark outside, so that was very exciting. It took everything for me not to cry, because lately when I see that she can do something that she's not been able to do, I get teary-eyed, and Monroe thinks, "Mom, what did I do wrong?" So now I just have to hold back the tears and then have those moments in my private space so that she doesn't think that she's doing anything wrong. It's so amazing what this gene therapy has done for her.
Thank you. So I'm just going to conclude here. One thing I want to emphasize is that molecular diagnosis is the driving force behind gene therapy, so it's so important to just have conversations with insurance companies and just communicate with them that there is an FDA-approved treatment, and we need to really figure out what the cause is so that we can decide if they have treatment. And there's obviously, besides this particular treatment, there's 6 or 7 in clinical trials right now. It really requires a team approach to get this done, so there is some infrastructure required, which thankfully we do have. Expertise with pediatric retina surgery I think is very important, and we of course have that between me and Dr. Lee, because many of these patients who are going to be treated are children. I kind of went through the outcomes, but like you saw in the video, we've seen amazing results with the young children, and we hope that this particular treatment will pave the way to future gene therapy trials here and elsewhere. So thank you very much.
Thank you. Any questions for Dr. Nagiel?
I noticed that the average of patients at a very young age to somewhere in their 40s. Do you expect, or have you noticed any changes in results in patients who are younger versus those that are older?
Yeah, we found that the younger patients and the younger they are, the better they've really done. So they're starting to have eye contact, they can do things that regular kids can do. Whereas the older patients have a more muted response, so they will have some increased light perception, so they'll be able to walk around at night and actually see lamp poles and see that somebody's walking next to them, or be sitting in their car and see that there's a driver next to them, whereas they couldn't before. But the younger children are now being able to read without a special big fat light on them, or go out to dinner at a restaurant and not carry an LED light over their plate so that they can see what they're eating. So it's really just normalized their life, and I think it changes their whole trajectory socially, motor skills, everything. Yeah.
Anything covered by insurance, or is it provided by the drug company?
It's all so far being covered by insurance. So initially we had to have some conversations with MDs of the various insurance companies, but CCS is actually, the government insurances have been very willing to pay for it. As you heard earlier, it's $850,000. But all the insurance companies, even though they originally denied, after speaking to them, they approved it. So we haven't been easier since the first year.
I had a technical question. In the OR, when you load the syringe, so you just basically draw it up from the vial, and then I saw a brief clip of it.
Yeah.
You fill it up in backwards through the cannula, and you probably have extra volume, I assume, than what you need to inject.
Correct. So we get it in a sterile syringe, so I'm actually able to handle it. I load a needle and backfill it into this Medlin microdose kit that I've already moved the plunger around so I make sure it's not stuck. And that ends up with, after I bleed it to the tip of the 38-gauge cannula, about 0.8 cc's. So I have plenty of extra, and usually I'm not even getting close to using it up. In one case, early on, we had to go to the backup syringe, so we get 2 syringes.
Aaron, do you think some of that improvement in kids relative to adults is cortical plasticity, or is it just better connections to the retinal level, or hard to say?
Yeah, it's a good question. Hard to say, but I definitely think that if you look at OCTs and these kids, the adults, there's just more cellular substrate there to take on the change. The adults just don't have enough photoreceptors and RPE.
I read an article that says that a child below 3 years of age makes every second something like thousands of connections in the cells of the brain. So the younger you treat these patients, the more connections they establish, and of course their vision is going to be better. And I think that's the plasticity that you mentioned, Dr. Patel.
Maybe fMRI studies and such might show differences in activation and things. Interesting. Thank you, Aaron.
All right, thanks.